Lesson 10, History Taking and Secondary Assessment. You learn how to conduct a primary assessment, which helps you to determine if the patient has any life-threatening conditions through checking level of consciousness, airway, breathing, and circulatory status. However, as you will learn in this chapter, you can obtain more information about the patient history through history taking and the secondary assessment, which includes interviewing the patient and bystanders, monitoring vital signs, and conducting a physical exam. As with the primary assessment in the case of serious injury or illness, performing and documenting a thorough history and secondary assessment can increase the patient's chance of survival. Okay, here's a scenario that we will be discussing in person. You are the medical emergency responder. You arrive at the scene of a motor vehicle collision, a fender bender, in which a woman who is driving her husband to the hospital because he was complaining of chest pain struck the car in front of her. A police unit is on the scene assisting the husband, who collapsed and apparently is unconscious. Your partner proceeds to help the police officer with the unconscious patient. You notice that the woman is clutching one of her arms. Okay, so this is an in-person scenario. Look at all the different factors to consider in this equation, and we will discuss this as an in-person portion of our lesson 10. Components of a patient history. Obtaining a full patient history involves several components. Key among them is the chief complaint, which will allow you to make the important distinction of whether you are dealing with a trauma or medical emergency. Other components to consider are the mechanism of injury or nature of illness, the presence and assessment of pain, as well as evaluating of any relevant medical information. Okay. So a little more detail about the chief complaint. The most important component of the patient history is the chief complaint. This is the reason why emergency medical services personnel were called to the scene. The best way to determine a chief complaint is to ask the patient, why did you call for EMS personnel? Record the chief complaint in the patient's own words. Keep in mind that the most obvious problem is not always the most serious problem. For instance, if a patient's arm is mangled in a car crash, it may appear to be the chief complaint until you find out the patient is having chest pain and crashed the car after blacking out. When interviewing the patient about the chief complaint, remember to ask the who, what, when, where, and how of the incident. Understanding the chief complaint generally makes it clear whether you are dealing with a trauma patient, someone who is injured, or a medical patient, someone who is ill, or a combination. The primary division will guide how you manage the patient. So next is the mechanism of injury or illness, a little bit more in depth. The next piece of information to determine is the mechanism of injury for a trauma patient or the nature of illness for a medical patient. In the case of an injury, it is important to find out how the injury occurred and determine what the forces were that caused the injury. This may help predict the specific type of injuries the patient may have. It will also help you determine whether there are any risk of a spinal injury. If the mechanism of injury suggests that there is, tell the patient not to move and provide manual stabilization by restricting motion and supporting the head and neck in the position in which you found it. Once you have dealt with the risk of spinal injury, follow the steps for trauma patients. These steps depend on whether there is a significant MOI or not, mechanism of injury. Okay, the next is pain. Okay, pain is something that obviously, you want to address, right? So if someone's in pain, we know where that pain is coming from, and that might help narrow down the problem, okay? Not necessarily, though. Other relevant medical information, okay? And other relevant medical information. Okay, so now we're going to be dealing with sample history. So what does sample stand for? Okay, so using the mnemonic sample, SAMPLE, determine and follow 6 items for the patient history: signs and symptoms, allergies, medications, pertinent medical history, last oral intake, events leading up to the incident. Signs include any medical or trauma assessment findings you can see, feel, hear, or smell. For example, this would include measuring blood pressure, seeing an open wound, or feeling skin temperature. Symptoms refer to what the patient records. For example, I'm having trouble breathing. I have a headache, or my chest hurts. For further symptoms, ask the patient to describe the current problem. Ask questions such as, where do you have pain? Are you feeling nauseated? Do you have a headache? Are you having any difficult breathing? Okay, next is deal with allergies. Ask the patient whether they are allergic to any medications, food, or environmental elements such as dust, pollen, or bees. Next is medications. Ask the patient questions to determine whether they are currently using any medications, both prescription and over-the-counter. Ask additional questions such as, do you take any vitamins or herbal remedies? Have you taken someone else's medications? Did you take any recreational drugs? Are you using any medical patches? Pertinent medical history. Determine whether the patient is under a healthcare provider's care for any condition, if the patient has had a similar problem in the past, or if the patient has been recently hospitalized or had recent surgeries. If the patient is female, ask if she is or could be pregnant. Last oral intake. Determine when a patient last had something to eat or drink and what it was. Also, ask if the patient has recently taken any medication, and if so, what? Events leading up to the incident. Determine what the patient was doing before and at the time of the incident. The events leading up to the incident could possibly help the mechanism of injury or nature of illness. Okay, next slide is the secondary assessment. The purpose of the secondary assessment is to locate and further assess the signs and symptoms of an injury or illness. The secondary assessment consists of a head-to-toe physical exam. It may only consist of a rapid assessment, rapid trauma assessment, or rapid medical assessment. Or it may also include a detailed physical exam at a later stage. If you find life-threatening injuries or medical conditions during the primary assessment, such as unconsciousness, severe life-threatening bleeding, no breathing, or no pulse, do not waste time with the detailed physical exam. Instead, focus your attention to providing care for life-threatening conditions. Complete a secondary assessment following the primary assessment once all life-threatening conditions are addressed and have been stabilized, if time and resources permit. Okay. So the secondary assessment is more, after someone is stable, we can ask questions and things like that and get more information. First, we want to address the more serious issue, the, life-threatening issues. And once we determine someone is conscious, breathing, stable, and communicate, then we can do a secondary assessment. Dots. Next slide covers dots. The mnemonic DOTS may be helpful during the physical examination for patients who have been injured. It stands for deformities. Deformities may include depressions or indications, parts that have shifted away from their usual position, parts that are more rigid or less rigid than normal, or obvious signs of broken bones. Open injuries. Open injuries may include anywhere there is bleeding, including the scalp. These may be serious, such as open injuries to the chest, or less serious, as in cuts and scrapes. Open injuries also include penetrating wounds, such as knife or gunshot wounds. Tenderness. Tenderness may be experienced even when there are no obvious signs of injury. When there is tenderness of the abdomen, it is important to determine in which quadrant the patient feels pain. Begin in the quadrant where the patient feels the least pain, so this does not influence the remaining assessment of the abdomen. Swelling. Swelling may indicate an accumulation of blood or air or other fluid in the tissues below the skin. In an extremity, it may indicate that the bone is broken. Pain assessment, okay? As part of a physical exam, if the patient is responsive, ask questions to gain information about pain. One method of questioning can be remembered using the mnemonic OPQRST, which stands for onset, provoke, quality, region, radiate, severity, and time. It can be used for both patients who have been injured and those who have a medical condition. Onset. What are you doing when the pain started? Was the onset abrupt or gradual? Provoke or palpitation? What makes it worse? What makes it better? Quality. Is the pain blunt, sharp, burning, crushing, or tearing? Region, radiate. Region, radiate. Where is the pain and does it radiate, spread? Do you have pain or discomfort somewhere else? Severity. On a scale of 1 to 10, how intense is the pain? Time. Where did it start? How long has it been present? How has it changed since it started? All right, so detailed physical exam. Once the focus history and physical exam have been completed and any life-threatening conditions have been managed, a detailed physical exam may be conducted. This exam is not carried out on every patient. It requires much more time than a rapid assessment to conduct, as it is more detailed, and so can only be performed when time and the patient's condition allows. Often it is conducted in the ambulance or other transport vehicle en route to the hospital. During the detailed physical exam, the mnemonic DCAP-BTLS may help you remember the signs you are looking for as you conduct your head-to-toe assessment. The letters stand for deformities, contusions, abrasions, punctures/penetrations, burns, tenderness, lacerations, swelling. Keep these types of injuries in mind as you check each major area. Remember to use each of your senses. Many of these types of injuries can be seen upon examination. By palpating, by feeling for injuries, you can determine if there are any deformities or swelling and if the patient is experiencing any pain or tenderness. Even if the patient cannot tell you, you can observe any grimacing on the patient's face. In addition to seeing and feeling for signs of injury, listen for abnormal breathing sounds. For example, gurgling or stridor in the upper airway. Auscultate. Listen to the lungs with a stethoscope for breathing sounds. You can also listen for the sound of broken bones rubbing against each other. Use your sense of smell. This is one way you can detect any unusual or unexpected odors, such as the presence of alcohol or a fruity smelling breath, as well as the possible presence of urine feces. As with any physical exam, try to keep the patient calm and comfortable. Rather than focusing on your findings, explain what you are doing to minimize any distress about the injuries. Do not move the patient unnecessarily if you suspect a head, neck, or spinal injury. So this is a detailed physical examination continued. Let's address the head. To check the head, gently feel for any deformities. If you feel a depression or soft area, do not place any pressure over the area. Look for blood or clear fluid in or around the ears, nose, and mouth. Blood or clear fluid can indicate a serious head injury. Is there presence of vomit around the mouth? Look at the teeth. Check the LOC again and note any change. Look at facial symmetry. Check the pupils. If they're unequal, this is an abnormal finding. Do they react to light by constricting and to darkness by dilating? This reaction is normal. If they remain constricted or dilated, this is an abnormal finding. Does the shape of the eyes look unusual? Look for bruising on the face, especially around the eyes. Next is the neck. To check the neck, look and feel for any abnormalities. Does the patient breathe through a stoma? A stoma is an opening in the neck to allow a person to breathe after surgery to remove part or all of the larynx, voice box, or other structures of the airway. The person may breathe partially through this opening or may breathe entirely through the stoma instead of through the nose and mouth. Are there any open wounds? Is the patient using the accessory muscles for breathing a sign of difficulty? Is the jugular vein distended, enlarged, and protruding? If the patient has not suffered an injury involving the head or trunk and does not have any pain or discomfort in the head, neck, or back, then there is little likelihood of spinal injury. You should proceed to check the other body parts. If, however, you suspect a possible head or spine injury because of the mechanism of injury, such as a motor vehicle collision or a fall from a height, minimize movement to the patient's head and spine. You will learn about spinal motion restriction techniques for stabilizing and immobilizing the head and spine. So now let's discuss the chest. Check the collarbones and shoulders by feeling for deformity. Check the chest by asking the patient to take a deep breath and then blow the air out. Ask the patient if there is any pain. Auscultate for lung sounds if you are trained to do so. Look and listen for more subtle signs of breathing difficulty, such as wheezing or diminished lung sounds. Feel the ribs for deformity. Examine the chest. Does it rise and fall without effort, or is there evidence of an effort to breathe? Are there any open wounds? Is the chest symmetrical? Now, abdomen. Next, ask if the patient has any pain in the abdomen. Expose the abdomen and look for discoloration, open wounds for distension, swelling. Are there any scars or protruding organs? Does the patient look pregnant? Look at the abdomen for any pulsating. If there is no pulsating, apply slight pressure to each of the abnormal quadrants, avoiding any areas where the patient had indicated pain. Next is the pelvis. Check the hips, asking the patient if there's any pain. Place your hands on both sides of the pelvis, push in on the sides, and then push down on the hips. Check for instability and any reaction to pain. Next is the extremities. Check only one extremity at a time. Look and feel each leg for any deformity. If there is no apparent sign of injury, ask the patient to move the toes, foot, and leg. Repeat the procedure on the other leg. Finally, determine if the patient has any pain in the arms or hands. Feel the arms for any deformity. Check limbs for symmetry and check the pulse. Look at color. If there is no apparent sign of injury, ask the patient to move the fingers, hand, and arm. Repeat this procedure on the other arm. Check for distal circulation and sensation in both arms and legs. Check capillary refill. So last, we have the back. Examine the back for any injuries by palpating equally along the spine from the neck downward with your fingertips. Check for any reaction to pain. Look for discoloration, open wounds, and any signs of bleeding. Your exam should be methodical and purposeful so that you do not overlook any details. vital signs. The initial set of vital signs provides a starting point for establishing a baseline to determine the status of your patient. The vital signs can tell you how the body is responding to injury or illness. Look for changes in vital signs as you provide care and note anything unusual. Vital signs are taken after managing life-threatening problems found during the primary assessment. They are normally taken after the rapid assessment is complete. However, if several responders are on scene, they may be taken simultaneously. Note that absolute values are not as important as trends. There are 3 major vital sign measures to be taken: respiratory rate, pulse, and blood pressure. You may also measure skin characteristics, color, temperature, and moisture, and pupils at this stage. Okay, here's more signs and symptoms of abnormal breathing. Gasping, okay? If someone is gasping, that's a sign of abnormal breathing. Noisy breathing, okay? So noisy breathing is not normal. We normally hear people breathing. We don't hear any noise or anything like that. That can be a sign of a problem or of an obstruction or to the airway or something, right? Excessively fast or slow breathing, okay? That's not normal, okay? Slow breathing is not normal. Fast breathing is not normal. Excessively fast. These can be signs of a health issue, and it can be an emergency. Painful breathing, okay? Being difficult for someone to breathe. That can be a problem, some injury or something going on with that individual. All right. All right. So, okay. Next is abnormal breathing sounds. Crackles, okay? That's not a normal sound, all right? Raunchy, okay? That's not a normal breathing sound. Stridor, okay? And wheezing. These are all abnormal breathing sounds that we have to take seriously. All right, next slide, we're dealing with abnormal pulse, okay? So an irregular pulse, it's kind of self-explanatory. You have an irregular pulse, and you have something going on there that should be taken seriously. Weak and hard to find pulse, okay? That could be a sign of a blood circulation issue, possibly, or something else, right? Your pulse is not very strong. It's not a good sign. Like a nice strong pulse is an indicator of good health and circulation. Excessively fast or slow pulse, okay? That can be linked to a serious problem, okay? So these are things that you have to consider. Okay, next we're going to deal with blood pressure measurement, okay? Here with equipment, right? We have a manometer, okay? A manometer, and then we have a stethoscope, okay? So, to measure blood pressure, you need 2 pieces of equipment. A manometer and a stethoscope. A manometer is made up of 2 main parts: an inflatable cuff that is wrapped around the patient's arm or leg, and a manometer. The cuff is made of fabric and comes in several sizes. It is a rubber bladder inside, which is connected at the end of a hose with a rubber ball called a bulb. A valve in the bulb opens and closes to control the flow of air into the bladder. The valve is controlled by a screw. If you turn the screw to the left, it opens the valve and lets the air escape from the bladder. If you turn the screw to the right, it closes the valve so that when you pump air into the bladder, the valve opens the air inside the bladder, making the cuff tight. The second part of the manometer is the manometer, a gauge that measures systolic and diastolic pressure. The numbers on the gauge show the pressure in millimeters. The higher the number, the greater the pressure. There are 3 types of manometers: mercury, aneroid, and electric. So we have measured in millimeters of mercury, systolic, okay, like we discussed. The force exerted against arteries when the heart is contracting, okay? Then we have diastolic. That's the force exerted against arteries when the heart is between contractions. Okay, next slide here, we're going to be dealing with ongoing assessment. Okay. Once you have completed the secondary assessment and provided care for any injuries and illnesses, provide ongoing assessment and care while you wait for more advanced medical care to arrive. The purpose of the ongoing assessment is to identify and treat any changes in a patient's condition in a timely manner and to monitor the effectiveness of interventions or care provided. Record additional findings and turn this information over to the next level of care. Okay. The patient's condition can gradually worsen, or a life-threatening condition such as respiratory or cardiac arrest can occur suddenly. Do not assume that the patient is out of danger just because there were no serious problems at first. Reassess the patient at regular intervals. Patients who are unstable should be reassessed at least every 5 minutes or more, often if indicated by the patient's condition. Reassess stable patients every 15 minutes or as deemed appropriate by the patient's condition. The physical exam and history do not need to be repeated unless there is a specific reason to do so. If any life-threatening conditions develop, stop whatever you are doing and provide appropriate care immediately. Reassessment includes the primary assessment, vital signs, chief complaint, interventions, and care provided. You are the emergency medical responder. We have a scenario here. The injured woman accompanies you to a separate area so you can assess her for injuries. She is still clutching her arm. After assessing this patient, you find no life-threatening conditions. Okay, and what steps do you take next after this? Okay, you find no life-threatening conditions. We go to a secondary assessment, or, where do we go to? So this is a scenario that we will discuss in person, that you can address in person. Pulse oximetry. Richmond. Pulse oximetry is used to measure the percentage of oxygen saturation in the blood. The reading is taken by a pulse oximeter and appears as a percentage of hemoglobin saturated with oxygen. Normal saturation is approximately 95 to 99%. The reading is recorded as 95 to 95% SpO2. Pulse oximetry also is used to assess the adequacy of oxygen delivery during positive pressure, ventilation, and the impact of other medical care provided. When monitoring a conscious patient's oxygen saturation levels using a pulse oximeter, you may reduce the flow of oxygen and change to a lower flowing delivery device if the oxygen level of the patient reaches over 94%. The percentage of oxygen saturation always should be documented whenever vital signs are recorded and in response to therapy to connect hypoxia. A reading below 94% may indicate hypoxia. Pulse oximetry should be used as an added tool for patient evaluation, as it is possible for patients to show a normal reading but have trouble breathing, or have a low reading but appear to be breathing. When treating a patient, all symptoms should be assessed along with the data provided by the device. The pulse oximeter reading never should be used to withhold oxygen from a patient who appears to be in respiratory distress, or when it is the standard of care to apply oxygen despite good pulse oximetry readings, such as in a patient with chest pain. Okay, next we are dealing with indications for pulse oximetry. Pulse oximetry should be applied whenever a patient's oxygenation is a concern and for the following situations: all patients with neurological, respiratory, or cardiovascular complaints, all patients with abnormal vital signs, all patients who receive respiratory depressants, morphine, example, diazepam, midazolam. Next is critical trauma patients. Pulse oximetry should be taken and recorded with vital signs for stable patients every 15 minutes and reassessed and recorded at least every 5 minutes for unstable patients. So these are factors reducing the reliability of pulse oximetry, okay? So these are things that would, to consider, that will make the pulse oximetry not so reliable, okay? Some factors may reduce the reliability of pulse oximetry reading include hyperfusion, okay? Poor perfusion, shock, for example, okay? Cardiac arrest, absent perfusion to fingers, okay? Excessive motion of the patient during the reading. Fingernail polish. Carbon monoxide poisoning. Carbon monoxide saturates hemoglobin. Hypothermia or other cold-related illness. Sickle cell disease or anemia. Cigarette smoking due to carbon monoxide. Edema, swelling. Time lag in detection of respiratory insufficiency. The pulse oximeter could warn too late of a decrease in respiratory function based on the amount of oxygen in circulation. Okay, and that concludes everything in lesson 10.